So I'll wait 1 more minute. I was saying we usually meet the second week of the month, and this is a reschedule, so maybe some people don't know or don't realize we have it today, but hopefully with my email, some people will be reminded. So let me share my screen. Okay. Oh, here is Megan. So, okay, so let me start. So today we are going to talk about infertility and mental health, how infertility affects mental health, how mental health can affect fertility, and kind of the interrelationship between the two. So first, we are going to start by what's the definition of infertility. So the definition is the failure to achieve a successful pregnancy after 12 months or more of regular and protected sexual intercourse, or due to an impairment of a person's capacity to reproduce, either as an individual or with his partner. And there is primary infertility and secondary infertility. So primary infertility is somebody that could never get pregnant. Secondary infertility is somebody that already had a clinical pregnancy and now for some reason can't get pregnant again. And when do you start doing testing for it? You know, so it's different depending how old is the woman and what her history is. So if somebody comes and has a medical history that can make them not being able to have children, or sexual or reproductive history, or their age, if they are over 40, or if you find any physical things that are going on that can impair their reproductive function, you start with the testing immediately. You don't wait. If there is no history or physical findings, you will wait 12 months in women under 35 years, and you tell them they need to try for 12 months. If they are over 35 but younger than 40, they need to try for 6 months, and then you start the evaluation and treatment. So it's very common, and it affects 8 to 12% of couples. And I found some mixed information about if it is more frequent or not in certain groups of people. But I found that the rates increase in Black women and Native American. And these racial discrepancies is not just in terms of having infertility, it's also associated, we also see it in access to care for sure, and also how the treatment goes, you know. So they saw that in Black, Hispanic, and Asian women, they have lower clinical pregnancy rates and live birth after in vitro fertilization and after oocyte donation compared to white women, which is, it's very sad, but it's the case, it seems. And not everybody that will go through the treatment will get pregnant. So that's important to know. And the older the woman gets, the more difficult it is to get pregnant. So there are female reasons, there are male reasons, and there are combination or unexplained reasons. So 35% of cases are due to female factor, 35% cases are due to male factors, and 30% are combinations or unexplained. For me, this is important because if you see, female factors are the same amount that male factors, but many times the woman is like seen as the one that has the problem, you know? So, and the male might take time to go to seek treatment or to seek evaluation. And yeah, that was very interesting to me because usually women go, and sometimes they go with their partners, but we see a lot of women that take the responsibility of it. The other thing I wanted to say is that for some people, they don't have infertility problems, but they need the fertility treatment to get pregnant. So like couples of two women that need to get pregnant, or a couple of men that needs a surrogate to have a child, or somebody that they had and that will be more if they had any treatment before, like chemotherapy that affected their gametes, you know. But there are some people that don't usually have fertility problems and they need a treatment, and that makes them more possible for them to have children. And I think this opened, like recently, it opened like a new possibilities for people that are in the same sex couples or non-binary or transgender that want to have a child. So what are female factors of infertility? So the most frequent one is polycystic ovarian syndrome. They have infertility in 70 to 80% of cases. And it's associated with acne, hirsutism, metabolic issues, and it responds to treatment many times, you know, so there are specific treatments for it that help women get pregnant. Then there is functional hypothalamic amenorrhea. These are women that don't ovulate. And what is that? It's basically women that have a strong emotional reaction, or exercise very much, very strenuously, can cause functional hypothalamic amenorrhea. Then, as I said, age, as the older the woman is, the more difficult to get pregnant. Then there is blockage of the fallopian tubes that can be women that had sexual transmitted diseases like chlamydia, gonorrhea, that can give the blockage of the tubes. Then very also common is endometriosis, that is associated with a lot of pain, also chronic pain. And these women actually suffer a lot, and many times they can't get pregnant. Then women that have fibroids, polyps in the uterus, congenital malformations. When I was in residency in Argentina doing my OBGYN residency, we were specialized in treating congenital malformations of the female reproductive tract, and women that didn't have a vagina and uterus came to us. And that sometimes is recognized later on in life, you know, when they want to start having intercourse or they want to get pregnant. And yeah, so these women can have obviously infertility. Then some women that have thyroid autoimmune disorders like Graves, Hashimoto, they might have difficulty getting pregnant. In terms of the male, the problems usually are caused for problems with ejection of semen, absence or low levels of sperm, or abnormal shape and movement of the sperm. And you can see it in different situations, like hormonal disorders, like thyroid problems, prolactin variations, varicocele, any men that had cancer and went through chemotherapy can affect their fertility, use of anabolic steroids, and alcohol, tobacco. There is some controversy about what happens with marijuana. Some studies suggest that it impairs fertility. Some studies suggest that that's not the case. But tobacco and alcohol can very much. And yeah, here it is. So in environmental lifestyle factors, smoking, excessive alcohol intake, and also being exposed to pollutants and toxins can affect the eggs and sperm. And also other things is obesity, can put a woman at risk of infertility. So, and that sometimes is associated with polycystic ovarian syndrome. So I created this slide for you to see how is the diagnosis of infertility. And when they do the evaluation, they want to get to the particular problem to understand what is happening with this patient and help them with their problem. So who is going through this evaluation? People that have infertility, also people that have recurrent pregnancy loss, or any genetic carrier status, if they have a genetic disease that can be transmitted to the baby, and anyone that will need donor sperm for some reason. And as I said before, it's very helpful in same-sex couples, in transgender men, and non-binary individuals. So, it starts with a very thorough evaluation, history evaluation, a physical exam, a very detailed menstrual history. You want to know if the woman is ovulating or not. And then it starts with all the tests that these women get, so they get ultrasounds. And when they are doing the treatment, they get serial ultrasounds, they get blood work for their hormones, they get studies of the cervix, they get the hysterosalpingography that is it can be painful, They inject contrast into the uterus and they see how the uterus is and how the tubes are, but that can be very painful. And then if you need something more like an hysteroscopy, laparoscopy, you might need surgery to see. And then the semen analysis and all the studies that the men will need. Might need also checking his hormones and evaluation of how he's doing physically. So it's very tedious evaluation and very invasive in some level. It's like your reproductive tract. So it can be felt very invasive. So you can imagine that the diagnosis and treatment of infertility can have a very profound impact, both emotionally and physiologically, on couples trying to conceive. The treatment can be very daunting, and we'll talk about that. And studies show that there is a 50% risk of having depression and anxiety and having relationship problems and social difficulties, which is a lot, it's not just what they are going through with the infertility that puts them at risk of psychiatric illness and having problems in their couple and with friends and family. So what are the reactions that to infertility? So some women feel shock, sadness, depression, as we said, anger, frustration. It can get them to have low self-esteem and low self-confidence. And this is what I hear a lot from patients. It's like a sense of loss of control. They don't have control over what's going on with them. And infertility is still a very private matter. So a lot of couples don't talk about it. And it's very difficult. Like I just saw yesterday a patient that was telling me that, every situation can be impacted by infertility. And she was in particular talking about social situations. I was asking her, what is she doing on the weekends? And she was saying that it's very hard to go to other people, to meet with other people, because some people just don't realize and might ask you, oh, when are you going to have kids? Or do you have kids? Or what's going on? And that it puts them in, and they don't discuss what's going on with them, and puts them in a situation very uncomfortable and might make them feel less than others. So the other thing I see a lot is that the fertility process affects the relationship with the partner. And that's it's a problem, because usually couples don't share the information, they just keep it in between the couple. And if on the top of that, you're having problems with your partner because of the infertility, that can really increase the risk of psychiatric disorders. There is a lot of social isolation and avoidance, especially of pregnant women and friends who have children. So this is all the psychiatric disorders that can happen because of infertility. So as I said, very common anxiety, depressive disorders, disorders of sexual function, that can happen for two reasons. One is because suddenly having intercourse becomes a chore. It's not more because you want to do it, it's because you have to do it to get pregnant. And the other thing is some of the medications that are used for infertility can decrease sexual desire, can affect sexuality. Then somatization, dysthymia, panic attacks, obsessive compulsive disorder. This reminded me, I had a patient who was doing infertility treatment. She had several trials of IVF. And then when she got pregnant, she couldn't believe it. So one day in the first trimester, we were talking and I said, how are you? She said, I keep doing pregnancy tests. And she took out a box, and in the box, she had 25 pregnancy tests that were all positive. And she just couldn't believe it. She was still doing them. There is social anxiety disorder, and that can be related to the fact that you start feeling uncomfortable with other people. What are they going to say? What you are going to say? There are eating disorders and alcohol and drug addiction. One thing that we see is that if somebody has infertility, they need a lot of support, but not just family, if they share their information, also professional support. So they can talk about what they are going through, and we see that lack of psychological treatment or ineffective therapy, low socioeconomic status, and lack of partner support are associated with increased chances of developing depression. So these women might not start with depression, but may develop it as the process is going on. And they also, another study showed that the reactions of relatives and partners that are negative regarding the infertility can be associated with higher levels of anxiety and depression and reduced self-esteem, as we said before. So as the infertility treatment progress, the relationship with the partners become less stable. There is also the fact that it's very costly to do infertility treatment. Many insurances don't cover it. There is a lot of out-of-pocket cost and also time commitment for the treatment, which means that women might not be able to go to work, so it will decrease productivity, or might lose certain, or go to school, or whatever it is that they are doing. They need to change their, everything needs to be concentrated in the fertility process, which is very difficult. And as I said, we were talking about social withdrawal and feeling of inferiority compared to their peers. So what is the effect of psychiatric disorders on fertility outcomes? It's a little bit less, we know less about that. We know that a woman that is smoking because she's so depressed, or drinking, or using drugs, that can affect the process of fertility. It can make them more at risk of not being able to conceive. What I was just saying, the stress of the fertility treatment in respect to how it affects the outcome of the fertility treatment, I couldn't find a particular answer to that. Like, studies were opposing in some levels. Some of them said that actually stress affects the process and the likelihood of getting pregnant. Some of them said that's not the case. It's very difficult to measure what happens because there are so many things intertwined, you know, like when you are trying to study somebody with infertility and seeing if it really started because the woman was having depression, or there was something else related. Did she have any unhealthy habits? Was she drinking? Was she smoking? Like, so it's so difficult to know what starts first and to really make the connection and see what is causing what. We know that eating disorders, we see them are very prevalent in women with infertility. So I will mention the two most common technologies that they use in assisted reproduction. And the most simple one is IUIs, intrauterine insemination. And what they do is they do ovarian stimulation with medication, several ultrasounds, they inject HCG, and they time the insemination of the sperm. And then they follow with progesterone. So even that this is the most simple one, you can see it has women is taking medication, the ultrasounds, the injections, they check blood levels of hormones. So it's cumbersome. And then the in vitro fertilization that women need to do daily visits for monitoring, serial ultrasound. They use injectable medications. They need to go through sedation and anesthesia for the egg retrieval. And then it's the process that the gametes are fertilized and the embryo is cultivated in the lab. And then they are transferred to the uterus. It can be directly transferred, or they might freeze them to use later. And some couples request to do genetic testing of the embryos to make sure they are good quality and there's no disease going on with them. But you can see, just seeing this, you can think about how difficult this process is. So these are the medications that are used for, some of them that are used for infertility treatment. And what I wanted to, I highlighted here, in bold, I put how many, all the psychiatric symptoms of the medications. So it's not just that you have to take them and they have a lot of physical symptoms. Some of them you need to inject every day. It's painful in the site of injection, but they also have mood symptoms because of them. And some of them create decreased sex drive, so it gets more difficult. Sometimes if you're trying to conceive without this, not without, but yeah, if you're also trying to have sex and have a good intimate life. So you see, the one medication that I forgot to put here is progesterone, actually. And progesterone can also, it depends what kind of progesterone. The one that is micronized, that is more natural, doesn't seem to cause any depression. But once the synthetic progesterone seems to bring depression too. So there is particular information on this. I had patients asking me about how their antidepressants can affect their partner if the partner is on antidepressants. And there is some information about it, very few. There was a study in 2010 of men treated with paroxetine or Paxil, and they saw that there were increasing the level of DNA fragmentation of abnormal levels of DNA fragmentation in men that took Paxil, and that affected fertility. Then after that, they did animal studies and human studies where they looked at the impact of these antidepressants, and they also saw that it can affect the sperm motility, the testosterone level, the abnormal morphology of the spermatozoids. So that was concerning. But then in 2021, they did a study using duloxetine, that is Cymbalta, 60 milligrams, and they didn't see any problems. They saw that these patients had a small decrease of testosterone levels, but wasn't clinically significant. So we don't know much about this really. If I need to choose a medication for a male that is trying to conceive, I might say use duloxetine, but the reality is that we don't know enough to make judgments about it. In terms of for the female partner, there are medications that we use for psychiatry that can also affect fertility. So let's say the antipsychotics can increase prolactin, and that can create infertility. Then also the antidepressants can increase prolactin in much less frequent levels than the antipsychotics, but it can happen. And lithium can cause hypothyroidism, and that can put the woman at risk of infertility. And the other effects that can be a problem is of these medications is weight gain, that the woman might not feel good enough about herself and might make it more difficult to have intercourse and be intimate with a partner, decrease libido, and also sexual dysfunction. So we know, and there are studies that show that psychological interventions can help to decrease anxiety and depression. And there is some thoughts that this might help with the pregnancy rate. There are studies about cognitive behavioral therapy in group settings that seems to be very helpful. They show that in the literature that couples who have less anxiety, stress, and depression, also those who received treatment for their stress, had a better way of dealing with the treatment, might make better lifestyle changes, and they feel less isolated, they function better in their marriage, and they are more able to accept the situation and the outcome of the treatment. Because if you remember, I said that 50% of couples are able to conceive, more or less. So the treatments for the psychiatric symptoms that will hopefully help also with the infertility are the best studied ones. Psychotherapy is cognitive behavioral therapy, and then relaxation techniques are helpful. So yoga, meditation, deep breathing, guided imagery are all helpful. Yes. The thing is, like when women come and say also, when you are thinking that a woman might need also medication for the treatment, and some women might be very anxious already about all the infertility process, they don't want to add something else to the possibility that it might not work. But the reality is that improving the mental health of the woman also helps her to be able to comply more with the process and be able to get pregnant. So that's what I tell women usually when they are trying to get pregnant and they are having psychiatric symptoms and might not want treatment for the psychiatric symptoms. So this is the information I wanted to talk about this because this is such a rich topic, and I think I don't know if you have patients with infertility, but I have many, and they really are suffering. It's kind of they're suffering in silence because they are very to themselves and to their couple, and that don't have much support while they are going through the process. So I wanted to know, like, if you have any thoughts, any comments, any questions.
One of the things that I often see is, like, I think infertility goes so closely hand in hand with like grief and loss. And it seems like there's so much when I'm working with clients with infertility, there's so much of a loss component, like grieving and grieving the loss of what we thought was going to be like a easy time getting pregnant and potentially even having kids. And then just the frequency that there's an infant loss during the infertility process. And so, like, if there is a miscarriage, or, oh my gosh, I have one woman who they did 8 rounds of IUI, got pregnant, and then went into early labor, and baby ended up passing away at like 26 weeks. And so there's just so much grief and loss attached to the infertility piece. It's like a really common theme that I see.
Yeah, I was also, when you were talking about it, I was thinking about, so there are situations where the woman can't get pregnant, like even with IVF, even doing all the treatment, she can't carry a pregnancy. So there is the question of, first of all, she might not be able to use her own gametes, so that's the first situation when they need donor, either sperm or oocytes, to get pregnant. So that's the first loss of thinking, I can't do it. My body can't do it, my body is defective. So that's one thing. And then there is some people that needs to go to surrogacy, and that's another big loss also in the process. I have few patients that have early menopause, and they feel so guilty because they were like maybe postponing having children because they were into their career, and they were thinking, okay, I will do it later on, or they were finding the right person to have the child with, and then they try. I had just one patient that got married, and she didn't even know she had problems having children, and now she's in early menopause, so it's so difficult, and there are so many emotions involved, and if you don't have the help to navigate first the treatment and then your emotions associated to it, and the relationship with your partner. Because what I see a lot is that women tend to take the burden of it and say, I'll give the least information to my partner, or I'll get him involved when it's needed, but they take the burden of it. And that's very, very difficult for them.
One client that I worked with, I'm a home visiting nurse, just for those of you that don't know me, and I work primarily with postpartum women, but also with prenatal women occasionally. And we had one client that she had a pregnancy when she was a teenager. That baby was given up for adoption. I think finding her life partner took her into her 30s, and then she had infertility issues. So there was a lot of grief and loss and guilt and all kinds of things wrapped up in all of that. And she also got pretty far in a pregnancy. I'm not sure how many weeks, but then felt as though things were going wrong. But I think her doctors were so used to reassuring her, they sort of overlooked some warning signs, and she lost the pregnancy. And so she was this was like their last shot. She got pregnant, and then she couldn't trust anything. She couldn't trust her body. She couldn't trust the doctors. And so I partnered up with her just to be a person that was outside of her marriage, outside of the system. This person was actually a counselor. And so, she knows she knows a lot, but trying to apply it to her own life and her own coping and her own situation. And I think she needed somebody outside of it to process some of the concerns and then just have a sounding board. And so I started working with her pretty early in her pregnancy, and that child thankfully is now almost a year old, and I continue to see her every couple months as she's returned to work and all of this. But just in your communities, a lot of communities, not all of them, but you know, where the bigger towns in Montana are, there are these home visiting programs. And I think sometimes matching a client up with a nurse who can help them prepare for the birth. They can just kind of have somebody else to verbalize all these concerns with or questions, and someone to process with, because they're carrying such a heavy burden with so much history, and they don't want to keep putting it on the same people. I think is what I see, you know.
It's really great what you do.
Yeah, so it's I would just encourage you to look in your communities if there's a, you know, because we're free usually through the health department for all people, and most home visiting nurses can do some prenatal support. So
That's great. That's really good. But yeah, that's what I mean, is that they really need the support. They usually, if not, they lack the support, you know, and that it's all the process is so difficult, and getting treatment. And like I have patients in some places of Montana, they don't have access to treatment, you know? So that's really sad for them and difficult. So, and when they have, it's so expensive what they have to pay. So, yeah. Any other thoughts, questions, feelings?
Sometimes we have people in clinic who, and this doesn't apply to everybody, of course, but they'd had an abortion in their young adult lives, and now they have trouble getting pregnant or keeping a pregnancy. And I think that adds a whole other layer of guilt, that they're being punished perhaps in some way. And that one is difficult to navigate, because that kind of self-flagellation, you know, it's hard to, like, you can tell them all day long that they're not being punished for their choices, but it's hard to hear, I think, for especially as the infertility continues or they have continual recurrent losses. That's one of the most challenging ones for my practice.
Yeah, I agree. I totally agree. I saw a patient a week ago. When she was young, she had 5 abortions, you know, and with her partner that she's now trying to get pregnant, you know, but at the time it wasn't the moment. And now she feels so guilty and so responsible. So she doesn't really want to involve the partner in all the process because she feels it's her fault. So she needs to take the burden of it. Yeah. And sometimes women, even if they didn't have the abortions, they see that their body is defective and they are responsible for the situation.
I also think, as a healthcare provider who does provide fertility consultations and assistance, how much we let the psychiatric impact of trying again and again and again, like at what point do we sort of tell these families, these couples, like, you should wait because you just need some time to sort of, you know, and we try to let them be ready at their own pace, but sometimes, you know, they just try to get pregnant every single month and without success, or they have several miscarriages month after month after month. And it's like, at some point, you know, you gotta take that pause, but it's hard to tell them that sometimes because they're so desperate, you know. I mean, there's a lot of desperateness that comes with infertility that is hard.
Yeah, that's totally true. Yeah. I think that's, in that sense, it's so important, yeah, to have for the couple to have a place where they can discuss it, you know, like a couples therapy, a place with somebody that is objective, that is non-judgmental, and can help them think through the process.
I had a question about the eating disorder percentage. 18 to 20% of women going through fertility have an eating disorder.
That's
Is
what I
that-
found in the literature.
Yeah, is that
So that
what's
is,
that about?
so that's not just anorexia and bulimia. It's also obesity and also eating disorders that are not, they don't meet full criteria, but they might have some symptoms, you know? So it's not just the main diagnoses that are patients meeting full criteria. It's also patients with symptoms of eating disorders that might not meet all the criteria. Any other thoughts? I get so relieved when people come for treatment, you know, and they ask for treatment for their mental health while doing the fertility process. I just saw a patient this week that she was going to start with the fertility process and she thought, I need a counselor to help me through the process, you know, and I thought that's so great, you know. So
Do you recommend when we do counseling for fertility, like for the fertility piece of it, you know, even if they don't score on their PHQ-9 or, you know, their anxiety, their GAD-7, that we suggest that they go see a counselor anyway?
I think so, you know, and after reading in the literature, they will most likely they will go through some kind of adjustment. You know, they might not fully be depressed or anxious, but they will go through some symptoms, and this will create difficulties at some point in their life. You know, if they're not lucky and get pregnant, maybe the first procedure, you know, or so I see that there is a lot of hope, and then the hopes go down immediately, you know, like and then there is a lot of anxiety, depression, and then the hopes come again because, you know, they tell you something in the treatment that might work, and then again the hopes go down, you know. So it's kind of up and down process. The other thing I wanted to say in terms of eating disorders is that not all fertility programs assess for history of eating disorders. And I had even patients tell me, you know, like, please don't say anything about my eating disorder, because if they know, they might not take me, you know, so people feel ashamed of it. But at the same time, some programs don't actually look for it. And for some people, if the eating disorder is active, it might be the reason for not getting pregnant, you know.
Would there be recommendations? So if someone was like still an active eating disorder, would there even be recommendations to move forward with any kind of fertility treatment, or would the recommendation be to, you know, be in a period of stability?
Yeah. So if somebody is actively with eating disorder, they don't go ahead with the fertility. It's like somebody that is actively using drugs also, you know, or somebody that is very depressed, that is, you know, like it's not stable, you know, and they might not, I know that for eating disorders, for sure, they wait. And people that have been through the process know that, so they might not want to say it because they are concerned that they might be kind of stigmatized also. If sometimes it's not, maybe the eating disorder was years ago, and you can go through the process now of fertility, but they are concerned that just mentioning it will make the reproductive endocrinologist feel that they can't do it. But yes, it's very hard. It's very hard also because of the society expectations of a woman. And some specific communities and populations, there's more pressure to have children, and that can make it more difficult. Any other thoughts? Okay, so next time we will meet on, February 8th, the regular time. I'll send an email to everyone to remind. I think we are going to talk about pharmacotherapy during pregnancy and postpartum, treatment with antidepressants and anti-anxiety medications. So hope it's helpful. And thank you for being here.
Thank you.
Sure,
Thank
thank you.
you.